Hi, this is Chris Good, and this is another video lecture of the Essentials for PSYC2050, our course at Georgia State Drugs, Behavior, and Society, and this is going to cover the mechanisms of drug action. Most drugs that are in production today originally were discovered in plants. An example here is ephedra, which is known as the Chinese herb mahuang. It contains a drug that's called ephedrine, and it was ephedrine that gave rise to a very popular stimulant, amphetamine. And there's lots of derivatives of amphetamine. But that first drug, ephedrine, was isolated in this plant. When a plant or any other type of naturally occurring sort of substance has some kind of effect on behavior, it is because there's a chemical substance in the plant that's interacting with the central nervous system. So this gets to one of the themes of the course, whether something is synthesized in the laboratory or packaged into a pill, or whether the drug source is in an entire plant product. It is the chemical action of some drug on the central nervous system that changes behavior. So in the U.S., we have three names for each drug that is produced by pharmaceutical companies. The first is the chemical name, and these follow the international rules of chemistry for naming chemical compounds. For example, there's a chemical that's, N2,5-dimethylaminomethyl 2-furyl-methylsulfonyl ethyl N-methyl 2-nitryl ethene 1-L-diamine. We give it a shorter name, a generic name, which is the name that all manufacturers of this drug would have to use, which is ranitidine, and that's the official legal name that's listed in this book, the United States Pharmacopoeia. But a specific company that has trademarked their brand of that particular chemical can name it whatever they want to. So this is trademarked, and it can be patented for up to 20 years. And for example, this drug that we've been discussing is Zantac, which is a proton pump inhibitor. It's used to treat heartburn. So your textbook gets into the classification of psychoactive drugs, and this is just one way of classifying these drugs, and it's by partly by their effect on behavior, partly by their mechanism of action. But let's take a look. So there's a couple that stand out here as sort of individual drugs on their own. They're not whole classes, they're specific drugs, and these are nicotine and marijuana. And this is because they don't really fit very well into categories that are based on their effects on behavior, like stimulants. Stimulants like cocaine, amphetamine, and caffeine have a stimulatory effect on behavior, on the central nervous system. Nicotine can act, it does have a stimulant effect, but it also has a calming effect as well, which we don't really understand very well. It may be in nicotine users, it's decreasing cravings or decreasing withdrawal symptoms. And marijuana is the other one. So marijuana has a calming effect as well, sort of like depressant drugs like alcohol, barbiturates, other sedatives. At different doses, though, it can act like a hallucinogen. Not that it brings on hallucinations, but it has effects on behavior similar to some hallucinogens, which we'll talk about later in the class. The rest are categorized either by their use, their effect on behavior, or their mechanism. So opioids are all share the same mechanism: morphine, codeine, heroin, methadone, oxycodone. All of those resemble the morphine-like compounds that are produced naturally in the brain, the endorphins, and a lot of them are derived from similar sources. Psychotherapeutic drugs are used to treat mental disorders, and these are extremely variable. So there are depressants that are used to treat disorders like anxiety disorders. There are antipsychotic drugs, which don't really fall into another category listed here, but psychotherapeutics are used to treat mental disorders. And finally, hallucinogens are those ones that bring on a hallucinatory state. And we're going to talk about all these different classes of psychoactive drugs. It's important to be able to identify specific drugs, and there's a reference that's put out every year called the Physician's Desk Reference. In the book, it describes all of the drugs that are currently in production. They include color photographs of lots of the pharmaceuticals that are on the market. And it's also the case that illegal drugs are sometimes shaped, marked, or packaged in some identifiable way. So the background image that you see here are illicit drugs. It's ecstasy, and they are pills that have been stamped with the manufacturer's, trademarked image, not illegally trademarked, but the some symbol that that a manufacturer uses. So Valium is and Prozac and OxyContin there are given as examples of some distinctive feature that identifies the drug by the way that it's shaped or packaged. And there's actually a lot of online resources here that you can use to check and make sure that your pharmaceuticals are what was prescribed. You can look up it and it'll show you a picture of what the pill is supposed to look like if you type in the name of the drug you've been prescribed. Let's go on and talk about drug effects. Every drug has specific effects that are the effects of that drug that depend on the chemical. Higher concentrations will have a greater effect, lower concentrations may have a lesser or even a different effect, but those have to do with the interaction of the drug with the central nervous system. But all drugs have non-specific effects as well, and these have to do with the expectations that the user has, the environment in which the drug is used, and these all change the way that drugs work in certain people. For example, it's been determined that the sort of social lubricant effects of alcohol, where it sort of gets people talking a little bit more and facilitates conversation, those are non-specific effects. If you deliver alcohol to people without them knowing that they have alcohol in a controlled, approved experiment, that doesn't happen. So it's not a specific effect that conversation increases or verbal communication increases when people have alcohol in their system. That has to do more with people's expectations. A related non-specific effects of drug are called placebo effects, which strictly means effects that are produced by an inactive chemical. And we use placebos, which are sort of inactive compounds that resemble a drug, to isolate the specific effects of pharmaceuticals when we're testing them. So, if a drug is to be approved to treat a particular condition or symptom, you want to make sure that that drug has specific effects and that it doesn't have to do with people's expectations about being treated. Placebo effects are really strong when treating certain conditions. Pain responds extremely well to placebos, and so does depression. And so it's very difficult sometimes to bring a new painkiller or antidepressant onto the market because you have to demonstrate that it's better than a placebo. But placebos work very well compared to no treatment at all, and so sometimes it's hard to get those approved. For the specific effects of a drug, we can talk about a dose-response curve. So there are different dose-response curves for different things that we're measuring. The example here is given of the dose of alcohol. And these are S-shaped curves that you can see start off at a very lower concentration, and a lower dose. And as we move to the right on the x-axis of this graph, we go to a higher dose. And not everybody is going to show the same response at the same dose. So you'll see that as we increase the dose, the percentage of people who show the effect of, for example, this first curve, slowed reaction time, increases. At a very low dose of alcohol, very few people have a slowed reaction time. But as we increase the dose, we see that proportion increases until we get to a dose that approaches 100%. So at a very high dose of alcohol, where really we're just beginning to see a few people lose coordination, and we call that ataxia. We see that almost everyone has a slowed reaction time. As we increase the dose further, the percentage of people suffering from ataxia increases to the point where, by the time almost everyone is displaying symptoms of ataxia, we're to a concentration where about a quarter of the people may slip into coma. So we can talk about dose response curves of different drugs for different behaviors at different doses, and just show the percentage of individuals who show that effect. Of course, if we go up to a high enough dose, we'll get to the point where we reach the lethal dose. It's very difficult to estimate that in people, but we are able to do that in animal test subjects. So it's not really useful to talk about the dose that definitely kills every single individual in a group, because there may be people or individuals in the individual animals that reach that lethal dose much earlier. So one of the most common metrics of the toxicity of the drug is to look at the LD50, which is the lethal dose where 50% of the animal subjects in a drug test would die from overdose. So we talk about the LD50. You could also measure the LD25 or LD75, but usually LD50 is the common measurement of the lethal dose. Of course, you can't do this in people. You can't really dose people until half of a group of people die, but we are able to estimate that based on just empirical accidental overdose data. We could also talk about the ED50, or the dose at which we get the desired effect in 50% of test subjects. And we can do this in people, though we often try it in animals first. So ED50 refers to the effective dose for half of the subjects, whether they're animal or not, to get whatever it is that the desired effect is. And finally, we can look at the ratio of these two, the lethal dose to the effective dose, to determine what's called the therapeutic index. Therapeutic index is the LD50 over the ED50, and what you want is a therapeutic index that is very, very large. So a bigger number means that the effective dose was small because it's in the denominator, and the lethal dose was large. So if you have a large lethal dose and a small effective dose, that means that the safety margin, the difference between the a dose that causes harm and the dose that causes the desired effect, is very big. So you want a big therapeutic index number, and that can be used to gauge that safety margin. Okay, now when someone ingests a drug, it's not going to stay in their body forever, and so the effects aren't, almost all the time, the effects are not going to be permanent. So this is a particular, this is a graph about a particular drug that when we administer the drug, right, the concentration of the drug increases as it gets spread throughout the blood supply, and as it increases, the effect could increase as well. So it would plateau at a certain point while the concentration is high, and then fall off as the drug is eliminated from the body or metabolized in the body. Now, we can talk about the mechanisms of metabolism, and we will in just a second. But I wanted to mention at this point half-life, because at some point the drug is going to be metabolized or otherwise inactivated, and we can measure how long that takes in terms of half-life. So we define half-life as the time it takes for half of the drug to be metabolized or otherwise inactivated. For example, if we measure the half-life of cocaine to be 1 hour, that means that after an hour, half of the dose that was in the body is going to be gone. So if a user ingests 20 milligrams, after an hour only 10 milligrams remain. We get into kind of a Zeno's paradox here, where after another hour, it's not that the drug is cleared from the body entirely. After another hour, half of that 10 milligrams remains, or 5 milligrams after 2 hours. After 3 hours, right, 3 half-lives, it's half of what was left before. Half of 5 milligrams would be 2.5, and so on and so on and so on. So you can imagine, well, then, you know, you never lose completely the cocaine that you ingest in your body. And while that's, you know, technically true, you know, we get down to the molecular level and it becomes sort of probabilistic as to whether there is still a molecule of cocaine in your body or not. On your way home, you can think about that. You know, if you're going home, at some point you'll be halfway home, and then another point you'll be halfway from that point, and another point you'll be halfway from that point. And if you think about it that way, you'll never get home. But you do. Okay. So there's lots of different routes of administration of drugs, and this is just a schematic of how drugs can get to the brain. They have to get there in the bloodstream. So the whatever route of administration is used, it ultimately gets to the brain through the blood. So let's talk about 4 different routes of administration. First, we're going to talk about the oral administration. We can talk about injection, either intravenous, which goes into the venous supply, or intramuscular, which goes into muscles that are also receiving a blood supply, and venous blood carries it back to the heart. We can talk about inhalation. Just a couple of heads up here. If you're not familiar with the circulatory system, just know that there are 2 halves of the heart, and you don't need to remember which one is which, but the right side of the heart, one side of the heart, is passing deoxygenated blood, right, venous blood, to the lungs where it picks up oxygen. Then the blood returns to the heart. It happens to be on the left side, and that's what pumps oxygenated blood to the rest of the body. So oxygenated blood is going to the places that need it. Your intestines, your muscles, your brain, right? And then the venous blood system returns to, you know, carries that deoxygenated blood back to the lungs to get reoxygenated. So think about it this way. When you inject something intravenously, it's venous blood, so you have to go through the lungs to pick up oxygen back into the heart before you get to the brain. When you inhale something, it's going into the blood supply that is getting oxygenated, and so you skip this venous return part to that side of the heart, right? So you're going straight to the left side instead of into the right side first. So technically, if you're measuring the distance from the site of administration to the brain, inhalation is the shortest path. However, you know, intravenous injection allows you to very, very quickly introduce could be very large doses of a drug into the bloodstream, even though it has to stop off at the lungs first. We'll see that oral administration takes the longest because absorption from your small intestine is kind of complicated. A drug has to be able to, you know, stand up to those heavy acids without it changing its effectiveness. It's got to be able to pass through the cells that line your small intestine and get into the bloodstream. So these are all qualities that a drug that's going to be orally absorbed have to have. Drugs that you take go through the stomach. They're digested by the enzymes and acids there. They go into the small intestine, and if it gets into the blood supply at that point, it's got to go in the venous blood supply first to the liver, and the liver contains lots of enzymes that can act on drugs to metabolize them. So the drug has to be designed to survive all of this. I will say that a lot of people think that drugs that are administered orally are absorbed in the stomach, and while that's true for certain drugs partially, most absorption of most drugs occurs in the small intestine. That's where, you know, nutrients are absorbed, and that's where that happens for drugs as well. Intravenous injection leads to some of the most rapid effects of drugs. It involves putting the drug straight into a vein, and then it goes right to the heart and to the lungs, to the other side of the heart, and then to the brain, and all over the rest of the body. You can deliver very high concentrations very rapidly. This is why when you go to the emergency room, they may decide to put an IV line to administer drugs to you quickly. It is dangerous for users to use drugs, illicit drugs in this way. You can damage veins over the time, they can collapse. Anytime you inject anything anywhere, there's the chance of infection being introduced into your body and into your bloodstream, so that can be very dangerous. And when we talk about intravenous use later, sexually transmitted diseases can also be passed, and other diseases. It can also be passed through by sharing needles with people who are infected. All right. Subcutaneous injection refers to injection under the skin, like this insulin pump in the upper left. Intramuscular injection involves hitting a major muscle group where there is a blood supply in the muscles. It's more of a slow release than going intravenously. Same with subcutaneous injection, where it's released more slowly. We can talk about inhalation. Now, you don't have to inhale something that's on fire. There are aerosols that can be inhaled directly into the lungs. There are powders that can be inhaled directly into the lungs, and then it goes right into the bloodstream that's being oxygenated, so it only goes through one side of the heart before it gets to the rest of the body. The effects are very rapid, although depending on the drug, the dose can be somewhat limited, so it depends on the effective dose on the drug. Finally, let's take a look at topical administration. So this is absorbing something through the skin. Absorbing through mucous membranes, right, occurs more rapidly. So when you expose something to the mucous membranes of your nose, as in this person is snorting cocaine, that is a way to get a drug a little bit more rapidly than simply rubbing it on your skin. There are tons of drugs that are delivered transdermally without contacting mucous membranes, such as the nicotine patch. There are other drug patches where the drug is absorbed more slowly and steadily directly through the skin. Interestingly, this image that we have of witches riding broomsticks is something that we might likely attribute to a method of exposing, delivering a drug to other mucous membranes. And we're going to talk about this again a little bit later in the course. There are hallucinogenic compounds that people thought that women would administer by exposing mucous membranes to the drug that was rubbed onto a broomstick. We'll come back to that a little bit later. All right. When the drug does get to the brain, there is a series of tight junctions around the blood vessels that are carrying the blood supply to the brain. And we call this the blood-brain barrier, and it serves a very useful purpose, so that those tight junctions prevent microorganisms from infecting the brain. They prevent some toxins from coming into the brain and having an effect on behavior. And there are some drugs that they really don't cross that barrier very well and can act only on the neurons that lie outside of the brain in the periphery, nerves that are in the periphery. To leave the capillaries in the brain, substances must be somewhat lipid soluble. They've got to be able to dissolve in fat. And there are lots of capillaries that are covered with glial cells that also prevent exit of compounds into the space between neurons. There are systems that may actively transport drugs outside of the blood-brain barrier and into the brain. And it's very important to understand that trauma to the brain, right, physical trauma, can break this blood-brain barrier. So if you're suffering from concussion, you may be more susceptible to the effects of certain drugs. Infection can also do this. So if you have inflammation in the brain or the blood supply to the brain, that can be a problem as well. All right. Drugs can interact with each other, and not always in ways that you might think. For example, if you're using two similar compounds like depressants, their effects can be greater than the sum of their parts and can lead to respiratory depression and death. We'll come back to that later in the course. Using stimulants and depressants at the same time seems like it would cancel itself out, but it's just not the case. They work on different transmitter systems, and they can interact in ways that can lead to really violent behavior. So you're stimulating maybe parts of your nervous system involved in aggressive behavior, and depressants might relieve inhibition of that behavior, and it can be pretty dangerous. Stimulants and antidepressants can actually sum to have interesting effects like overexcitement, arrhythmia, high blood pressure, and cocaine and alcohol, cocaine and several other substances can produce toxic byproducts. Cocaine and alcohol combine to produce cocaethylene, which is a neurotoxic substance, but it also has behavioral effects in addition to the separate effects of cocaine and alcohol. For any prescription drug that you get, you will have a warning about drug interactions, and read that carefully, and also make sure you let your doctor know about any nutritional supplements that you might be taking. If they have an effect on behavior, it's because the nutritional supplement contains a drug, and it may interact with other drugs that are similar or even different from the drug that you are prescribed. All right, once the drug is into your bloodstream, your body starts working on it to excrete it from the body and or to metabolize it. The key liver enzymes that come into play to metabolize drugs. And remember, metabolism literally means taking something apart. So these are enzymes, they're proteins that grab onto a drug molecule and literally snap it into its component parts. The opposite of metabolism is catabolism. There are other enzymes that grab components and stick them together. So there's this whole family of over 700 liver enzymes called cytochrome P450. And this group of these hundreds of different proteins are involved in the breakdown of a lot of different drugs. When this enzyme snaps drugs into their component parts, those parts don't necessarily have the same action of the drug. Sometimes they do. But the resulting parts can then be excreted by the kidneys. We've already discussed half-life, but it's interesting. I want to say one more thing about the cytochrome P450 family. There are subfamilies of enzymes in this group that can be responsible for the interaction of certain compounds with drugs. Many of you have heard of the grape juice effect. So grape juice can either greatly increase the concentration of a particular drug that you're taking. That's one effect that it can have, and it can prevent other drugs from having an effect. And the reason that grapefruit juice has this effect is because of its interaction with the liver. Grapefruit juice contains a particular compound that a specific type of cytochrome P450 enzyme is needed to break down. And if you're using that enzyme to break down what's in the grapefruit juice, it might not be available to break down the similar compound in a drug that you're taking, which means that that compound can, really build up to much higher levels because you don't have enough of the enzyme that's being used. The liver, like the brain, responds to continued exposure to a drug so that it's going to ramp up the production of liver enzymes in the case of continued exposure, right? So if you keep taking a drug, your liver's going to make more of the enzyme that's necessary to metabolize it. And this may be one mechanism of physiological tolerance or pharmacodynamic tolerance. So we've already talked about how neurons can change their sensitivity to a particular drug after repeated use, but the liver can do that as well. When you stop taking the drug, those changes to both the physiology of the central nervous system and to other organ systems like the liver may be responsible for withdrawal reactions. Finally, there's an aspect, even though we know that it has a physiological mechanism, there's an aspect of behavioral tolerance as well. So the drug may not induce those physiological changes at the level of the neuron and at the level of the liver, but they may have a reduced behavioral effect as drug users learn to compensate for whatever impairment the drug may impose on the nervous system. And you can think of lots of examples about this. People will, pay attention more when they're driving under the influence of particular drugs. They may think that they're compensating enough to drive normally. That's never the case. But we'll continue to talk about that as we go into the different drug classes, which we'll begin by talking about the stimulants in our next video series.